So I'm going to talk about the miscarriage, lessons for correct diagnosis and management. We meet women at the emergency department with bleeding in early pregnancy that have or not have lower pelvic pain. We can also meet women that their regular viability control of the pregnancy. And in those cases, we can find an intrauterine viable pregnancy. Some women turn to have a miscarriage. Some turn out to have an ectopic pregnancy. So I'm going to talk about a particular miscarriage in this lecture. So how do we diagnose miscarriage? Of course, patient history is a very important um, item here. So we have patients that probably know the time of the last menstrual period, and we know that the history about the vaginal bleeding and about the pelvic pain. But of course, we have to do the diagnostic. So first, what we do is a clinical examination. So during clinical examination, uh, uh, we might find pregnancy tissues in the vagina. We might see the open cervix. We might see the heavy bleeding without visible pregnancy tissues. But for clinical examination, is important to assess what is going on with the patient and where in the stage of the early pregnancy the patient is. And of course, the ultrasound is playing a very important role in this. So how do we know that miscarriage is ongoing? For the ongoing miscarriage, we will see pregnancy products in the vagina. And of course, we might see them in the cervix. We can see them protruding through the cervix. And if we do not see any tissues, but we have a patient history with the heavy bleeding, with the clots, so we might see or palpate the cervix open. First, before talking about the miscarriage and ultrasound, we have to talk about the viable intrauterine pregnancy. It is very important to know how early pregnancy looks like for each gestational week and what structures we have to assess when we look at the early pregnancy using ultrasound. So, of course, what we look at the gestational sac, we look at the shape of the gestational sac, we look at the yolk sac. We can see and assess the shape and the presence or absence of the yolk sac. And then we look at the embryo, if we see any embryo. And we also have to assess the amnion, which is also an important structure, particularly for the prognosis of the early pregnancy. So knowing all these structures and knowing what the normality of these structures at ultrasound is essential when we assess women with early pregnancy. So here you see several viable pregnancies with ultrasound different from gestational week. So in my lecture, I will show you several ultrasound images, and I just want to talk about the orientation of my ultrasound images. So in order for you to orientate, my images will be orientating like this, with the anteverted uterus and with the urinary bladder in front and the pouch of Douglas in behind. So if we look here, we see the thickened endometrium, we see the trophoblast around, and then we see the gestational sac with the yolk sac inside. Here we can see also a small embryo, and of course this is not a video, but we might see also some activities in like heart activity in that. Then we can also see look at the yolk sac, and of course assess the location of the pregnancy, which is also very important in the assessment. So we have to locate the pregnancy as well in the uterus. So here you see series of the normal intrauterine pregnancies, and here as well with advancing gestational age, we can also see the measurement of the crown ramp length of the pregnancies depending on which week we are. And of course, in larger embryos, we can see also the heartbeat at ultrasound. So what about the prognosis at ultrasound? There are some signs that might say that this woman might have a poor prognosis for this pregnancy to successfully develop. And when we look at the gestational sac, it could be irregular or low located sac. Of course, maybe low implantation, but if we do not see particularly if the pregnancy is viable and we have a low located sac, we might suspect that the sac is on the way out from the uterus, going to be expelled. Then we look at the amnion, and amnion should be approximately the size of the embryo. So if amnion is missing, if we see that amnion is too small or too large, which means that larger than the CRL, then it's not normal amnion, and it might be that it might be a sign of the poor prognosis for this pregnancy. Then we also assess the assess the fetal heart, and we know that fetal heart should be above 10, about 100 beats per minute if the pregnancy reaches 6 weeks. There is some biological variation, of course, but if we see a low heart rate that is below 100 beats per minute and the pregnancy is at least 6 weeks of gestation, we might consider it being a sign of poor prognosis, even if there is some heartbeat. And of course, the yolk sac could be too small, too big, missing, or irregular. We do not measure it, but we can just assess it visually and see the morphology of that. So these are the signs of that might be considered for poor prognosis in early pregnancy. So here are some cases for you where we can see that there is this is a gestational sac. We can see the yolk sac, and we see the amnion and a small embryo. As you see, this is the too large amnion in this case, and this pregnancy, even with this small hyperechoic structure considered to be embryo without heart activity, what could be considered being poor prognosis. We will talk about the criteria for diagnosing miscarriage, for conclusive diagnosis later during this lecture. And again, here we see a larger embryo. We see the embryo without any heart activity. Of course, this is a clear sign. We have quite large serial in this case. Here we see the irregular yolk sac in this particular case. So for the ongoing miscarriage, of course, our clinical diagnosis is very important, but of course, sometimes we can also see the situation at ultrasound. So here we can see the cervix. This is the cervix, and we see the cervix is open. So here is the content clots, where pregnancy tissues protruding into the vagina and also leaving the cervix. So this patient was heavily bleeding during ongoing miscarriage. And of course, we have no circulation in the tissues, so it means that we have no viable tissue in this case. So how do we know if this is a viable or non-viable pregnancy? So again, we can assess the structures, but for the conclusive diagnosis, we have to have some criteria. So what do we have to look? Shall we look at the size of the gestational sac? Shall we rely on CRL? Or do we need always to see no heartbeat in the embryo? First, let's look at the gestational sac, and let's look how to measure the size of gestational sac. Here again, if you use the mean diameter of the gestational sac to diagnose a non-viable intrauterine pregnancy, we need to know how we should measure the gestational sac. Here we have quite a huge gestational sac, and this is empty gestational sac, but to know, we need to know if there is a miscarriage, we need to measure it. So we should take 3 measurements that are perpendicular to each other, and we measure twice in one direction, thereafter turn the transducer with 90 degrees and measure the third diameter. And then of course we add them and divide in 3, and we have a mean diameter, or MSD, for the gestational sac. So some of people are making these 3 measurements in different ways. So we take one horizontal view, and some doctors are measuring twice in the vertical. This is not correct. Because why? Because this measurement is the same as this measurement. So don't measure in this way. Again, measure in this way for your 3 measurements in order to get a correct mean diameter of the gestational sac. It will be very important for your diagnosis of the non-viable intrauterine pregnancy. Can we look at the growth of the gestational sac or growth of the embryo to diagnose a miscarriage? Of course, we do follow-ups on these pregnancies, and we measure the size and we assess there been any growth or not. However, we cannot rely on the mean gestational sac. So here is a study that was published before the new criteria of miscarriage have been proposed. So they included intrauterine pregnancies of uncertain viability that had empty sac and no embryo with mean gestational sac diameter below 20 or below 30 millimeters, depending on the center, or embryo without heartbeat with CRL or below 6 or below 8 millimeters, depending on the center. It was a prospective observational study. So they have recruited 1,060 patients, and 359 of them came for a follow-up scan because the aim was to compare these two scans. And out of these, 460 had no yolk sac and no embryo, so they were empty sacs. 419 had yolk sac but no visible embryo, and 179 had embryo but without heartbeat. And the scan was repeated in 7 to 14 days later, and the outcome was the viability of the pregnancy at 11 to 14 week scan. So let's look at the change. So what we look here, we look at the change in an MSD, which is mean diameter of the gestational sac, and at the a change in CRL, crown rump length, um, between the first scan and between the growth. So this is the difference, the change in the diameters. And if you see the blues are those of the viables at 11 to 14 weeks, and red are non-viables. And as you see here, particularly for MSD, there is an overlap in growth rates between the viable and non-viable pregnancy. That says that there is no cutoff for the growth of mean gestational sac diameter, below which viable pregnancy could be safely excluded. So don't assess the change in mean gestational sac diameter between the two examinations in 7 to 14 days because of the biological overlap. And if we look at the cutoff value of CRL, so CRL growth of 0.2 millimeters a day was also always associated with a miscarriage. It means that if we have very slow growth, 0.2 millimeter a day, it is always associated with miscarriage if we repeat a scan in 7 to 14 days. So how should we define a non-viable pregnancy? So again, based on the same patient group, 1,060 patients, out of these 473 were viable and 11 to 14 week scan, and 587 were non-viable at the scan. And in here it was assessed the size again of the mean gestational sac diameter and of the CRL. And if we could look here at the cutoff values for mean gestational sac diameter, if there was no yolk sac and no embryo to predict the viability, we can see that if we check, for example, 16 millimeters of mean gestational sac diameter, the cutoff that has been used for a while, for a long time ago, we can see still that we still have false positives. So it's 4.4% of patients will still have a viable pregnancy, and we reach the 100% specificity, which means zero false positives at the 21 millimeters in gestational sac. Of course, sensitivity is very low in this case, but if we look at the specificity, which I think is the most important, because we do not want to miss any viable pregnancies and treat them as miscarriages, it was reached at the 21 millimeter in diameter of in gestational sac. And if looking at the pregnancies where there was a yolk sac but there was no embryo, the scan to predict viability at week 11, 14, again we can see that 100% specificity, no false positives were reached at 21 millimeter of mean gestational sac. What about CRL? If we look at CRL, we can see if we choose cutoff between 5 to 2 millimeters, we will have 8.3% of pregnancies that are false positive, 1 out of 10, still be viable. So the zero false positives were reached at 5.3 millimeters of CRL. It means that this is the cutoff where in the study no viable pregnancies were found after that cutoff of the CRL. So we have to look directly to this paper about the inter-observer agreement. for the reproducibility of gestational sac measurement and coronal plump measurement at 6 to 9 weeks. And we can see that if we look at the limits of agreement for first for CRL, so inter-observer agreement was 8.9 and 11.4%. And for inter-observer agreement, it was plus minus 14.6%. But if we look for the gestational sac, inter-observer agreement was plus minus 18.8%, almost 19%. What does it mean? It means that if we measure mean gestational sac, if it's measured, for example, at 20 millimeters by the first observer, prediction interval for the second observer would be between 16.8 to 24.5. It means that the second observer would measure it in this interval. And for CRL, if we say that CRL is 6 millimeters, the interval for the second observer would be between 5.4 to 6.7 millimeters. This is where the measurement of the second observer would be put. So it means that we need to have a range, or we need to increase the cutoff for both MSD and CRL in order not to miss the viable pregnancy and treat it as a non-viable pregnancy. So again, therefore, we go back to the first paper. Therefore, based on the inter-observer variability, and it has been concluded that current definitions are unsafe, and recommendations were to use a cutoff of mean gestational sac diameter of more than 25 millimeters, which it means in the correct measurements, as I show you, if we use mean the diameter out of 3 perpendicular diameters. And also for CRL, if we see an embryo, it should be more than 7 millimeters without any heartbeat as a cutoff for non-viability. And this is to minimize the risk of false positive diagnosis of miscarriage and, of course, patients that are mistreated and viable pregnancies interrupted. So just to repeat, diagnosis criteria for non-viable pregnancy today they are empty gestational sac, more than 25 millimeters, and mean diameter of 3, or coronal plump more than 7 millimeters, and no visible heartbeat. So how to manage this patient? Of course, it's always safe to get a woman for follow-up, even if you have the criteria for miscarriage at the first examination, particularly for less experienced examiners. It's always advisable to take women in follow-up, and particularly in those that we, of course, do not reach criteria, we cannot see conclusive diagnosis of miscarriage, take patient in follow-up in 10 to 14 days or in 11 to 14 days. Because, as I've shown you, there is a biological variation of growth of mean gestational sac and also CRL, and it overlaps in viable and non-viable pregnancies, and follow-up always is safe. And if we at follow-up for at least 14 days, in case of earlier empty gestational sac, we do not see any heartbeat today, we can say that the diagnosis of non-viable intrauterine pregnancy is conclusive. And if visible yolk sac was during the first ultrasound examination, and we do not see any heartbeat, at least at the next scan, at least 11 days later, we can see that this is a conclusive diagnosis of non-viable pregnancy. And very shortly about how to manage when we have a conclusive diagnosis, we have to choose between expectant management. We can choose the medical treatment, misoprostol, or in combination misoprostol and mifepristone, or surgical evacuation, which is probably not the first method we advise for the patient. And just to show you very shortly, a randomized double-blind placebo-controlled trial where mifepristone was and misoprostol was used versus misoprostol alone, and in total 2,746 women assessed for eligibility, and randomized total is 711, and with primary outcome available 348 in each arm. And they were randomizations 1-to-1, and in the first group, women received mifepristone, and thereafter single dose of misoprostol, sublingual, oral, or vaginal. And in the second arm, it was a placebo instead of mifepristone, and also the same for the misoprostol that has been administered 2 days later. So just show you very shortly about the primary outcome was set for the failure to pass the gestational sac spontaneously within 7 days after random assignment, and we can see that women that received placebo plus misoprostol were more likely to fail to pass the gestational sac spontaneously within 7 days compared to those that got the combined treatment. And for the secondary outcome, which was surgical intervention to complete miscarriage, we can see that more women in the placebo group required a surgical intervention. And we can also see for the secondary outcomes that the outcomes were very similar between the groups. And it has been concluded that mifepristone and misoprostol was more effective than misoprostol alone in management of miscarriage. Just a couple of slides to finalize my presentation. We scan patients at the different gestational weeks. We scan patients at sometimes very early pregnancy. Be very careful. Look for the structures, but also look for the location of the pregnancy. We can see this is a very early pregnancy, probably with a very small gestational sac inside. Here we have also an early pregnancy with a gestational sac, but we can see clearly that this pregnancy is located in the pregnancy scar. Here we have another case where we can also see that we have some small structure intrauterine, and we have talked about the ectopic pregnancies. We have to know that the true gestational sac is located eccentrically and should have a hyperechoic rim. And of course, if we see something, we have to complete our scan to be systematic, because here in this case, we had saw a very small cystic structure, which was not a true gestational sac, but we could see instead an ectopic pregnancy around. So just be careful, don't blame all pregnancies for miscarriages. We have to still search for probable pregnancies anywhere. Here we have a pregnancy in the cervix, for example. So do your systematic scan and assess the in the systematic manner if you see a structure that you believe it's a miscarriage. So what are the lessons of my lecture? I have told you about the current ultrasound criteria for non-viable pregnancy, that is empty gestational sac of 25 millimeter or more in mean diameter of 3, or CRL more than 7 millimeters without heartbeat. And remember how to take correct measurements of the gestational sac. And in case if its viability is unclear, or you see an unviable pregnancy, in particular in the hands of less experienced examiners, follow-up might be useful in 11 to 14 days, and it is safe. Thank you so much. So now it's time for our last lecture on this webinar, and I would like to invite our next speaker, Professor Simon Marr. Simon Marr works in Australia, in Melbourne, and he's a medical director at Monash Ultrasound for Women. And Simon is very well known for both obstetrician and gynecologists because he's doing both obstetrical and gynecological ultrasound at an expert level. And Simon is going to share with us his knowledge on 3D ultrasound today, and we'll talk about the 3D evaluation of ectopic pregnancy. So please, Simon, over to you.
Good evening. My name is Simon Marr. I'm an obstetrician gynecologist from Melbourne. Many thanks for the invitation to be part of this early pregnancy care webinar. Thanks to our sponsor, Samsung, and apologies to Ligita, Maya, and Ilan that I can't be with you this evening in person. My talk, which I'll be covering, is on the classification, diagnosis, and differential diagnosis of ectopic pregnancy. So I'll not be focusing on management, but rather sonographic approach and clues to diagnosis and differential diagnosis when faced with this common and rare forms of ectopic pregnancy. So I'll start my talk now. Management of ectopic pregnancy. The talk is divided into the following sections: an introduction focusing on tubal ectopic pregnancy, and then the rarer forms of ectopic pregnancy, and finishing up with some summary and comments. If we look at the ESHRA classifications of ectopic pregnancies, you will note there are 15 different types of ectopics, 13 involving the uterus and tubes, and 2 involving the ovaries or intra-abdominal ectopics. You will note for the ESHRA classification, almost all ectopic pregnancies now include 3D evaluation, and this is instrumental in identifying the exact location and characteristics of an ectopic pregnancy. And therefore, I will pay homage to not just 2D, but 3D evaluation of these pregnancies. If you look graphically at ectopic pregnancies, they can be divided into this group of 9, and I will go through these one by one. but I find that the graphics of the location of both the intrauterine pregnancies, lateral ectopic, and other ectopic pregnancies is very helpful when you understand the graphics in my description comparing to the sonographic findings. I'll start with the most common ampullary ectopic pregnancy. When we look at these, they represent about 80% of ectopic pregnancies in the fallopian tube, the most common site. When we look at these, we frequently will have a history of pain, bleeding, and amenorrhea. On ultrasound, we look for the findings of an adnexal mass, gestation sac, and about 10 to 15% of them will have a live embryo necessitating surgical intervention, and therefore very important to determine whether there's heart motion present. And then look for blood in the pouch of Douglas, which doesn't always necessarily mean that there's rupture. It may be leakage from the fimbrial end of the fallopian tube. So let's go through these. As you sweep from right to left, you see in a mid-sagittal section the uterine cavity is empty in a patient with pain and PV bleeding. As we sweep out to the ovary, we then appreciate there is a soft tissue mass sitting immediately adjacent to the ovary. We take the same patient and acquire a 3D volume, and the point I will make in this 3D volume, it is far easier to appreciate the trophoblast ring and surrounding tubal edema on 3D with volume contrast imaging and volume speckle reduction imaging. 3D, in fact, becomes a very powerful tool in distinguishing the exact location of trophoblast, and I will make reference to this throughout the talk today. Compare the trophoblast ring here on 2D, which is indistinct, and clear, which it is here demonstrated on 3D evaluation. So 3D doesn't always necessarily mean rendering, as is demonstrated here. This is taking a volume of the ectopic pregnancy and then demonstrating the internal echotexture of the gestation sac using 3D technologies. When we rotate on this around the y-axis, we can see it's not actually spherical, but rather it is a disc-like structure. Not surprising, consider it is compressed by the fallopian tube. However, let's go to a far more subtle case where the HCG is only 250 units with a left iliac fossa pain and PV bleeding. You can see the blood within the uterine cavity. There's no gestation sac. There's no evidence of retained products of conception. When you look at the adnexia, you see the ovary coming into view here, but there's a very subtle, indistinct soft tissue mass that sits beside the ovary just here. You could easily pass this as being bowel. However, when you take a 3D volume of this area, you will begin to appreciate that you are looking at an ampullary ectopic pregnancy. Again, you would go to 3D with VCI static, and here, as you translate through the volume, you begin to see that this is the ovary with follicular development, and this tissue here is all trophoblast, and this here is tubal edema. The power of 3D with volume contrast imaging and with volume speckle reduction imaging allows us to distinguish the hyperechogenic trophoblast from the tubal edema. Remember, it's the trophoblast that's the aggressor. How much trophoblast is, the more likely it is that it is going to rupture. Not only in terms of determining the volume of trophoblast in terms of the possibility or likelihood of rupture, it also allows you to clarify these complex ectopics. When you sweep out to the pelvic sidewall, you see gross enlargement and edematous fallopian tube. It's hard to work out exactly what is going on in this patient. However, when you then take a 3D volume and this patient at 8 weeks and 3 days of gestation with pain, bleeding, and slowly rising HCG, you now begin to appreciate that there are in fact 3 gestation sacs. In fact, this is a trichorionic triplet ectopic pregnancy in a fallopian tube. Again, this only became possible to realize this on a 3D volume acquisition. Let's move to the interstitial ectopic pregnancies, and these can be particularly challenging because they maybe mimic the appearance of a lateral intrauterine gestation or a lateral ectopic pregnancy, which I'll come to talk about in a second. The interstitial may be divided into partial interstitial or complete interstitial, and then I'll talk about the isthmic tubal ectopics afterwards. So, when you look at this axial section, and it's the most important section because you look at an axial section at the uterine cavity, and you here see the gestation sac, embryo, and yolk sac, but you can see there's a band of muscle tissue separating the uterine cavity from the ectopic pregnancy, which is positioned in the interstitial portion of the fallopian tube. This is a complete interstitial ectopic pregnancy. When you look on 3D on the same axial section, you can measure the distance between the outer rim of the trophoblast and the outer edge of the uterine cavity. It becomes far more impressive, however, when you look on 3D coronal section. Here's your triangular uterine cavity, which is empty, no blood, no gestation sac, no retained products. But here you have your complete interstitial ectopic pregnancy separated by a band of muscle tissue. The partial interstitial ectopic pregnancy, however, is much more challenging because you see now the ectopic abuts the uterine cavity at the fundus towards the left tubal ostia. And you can appreciate that as you sweep through this on 3D evaluation. Now you can see on 3D on a coronal section that here you have the continuity of the uterine cavity with the trophoblast tissue, making this a partial interstitial ectopic pregnancy. Once you reach on these two images, that communication with the cavity brings us to that classification of a partial interstitial. Then moving further along the fallopian tube is the isthmus tubal ectopic pregnancy. In this case, there is no surrounding myometrium, unlike the partial and the complete interstitial, which I've just described. As you sweep through this in the coronal section, you see this is a heterotopic pregnancy. There is an intrauterine gestation, but there's also an ectopic pregnancy in the interstitial portion of the fallopian tube in a patient that's 8 weeks and 1 day of gestation. You can see the ectopic is significantly smaller gestation sac and embryo when compared to the intrauterine, which is the norm. Let's move on to the eccentric intrauterine ectopic pregnancy, because these are the eccentric intrauterine pregnancy, because these are the pregnancies which mimic the appearances of the interstitial, particularly the partial interstitial. If you look at the eutopic pregnancies, there are really two types that concern us. There's the lateral eutopic, which we used to previously call eccentric intrauterine pregnancies, or the low eutopics, which are positioned low within the uterine cavity, which may mimic the appearance of a cervical ectopic pregnancy, or indeed a cesarean scar pregnancy in a patient who's had a previous cesarean section. With regard to the Escher guidelines, it shows this triangular appearance to the uterine cavity. However, we all know that in many instances the uterine cavity is not triangular, and if you have a pregnancy positioned up in this area here towards the right tubal ostia, or in this case towards the left tubal ostia, or in this case towards the right tubal ostia, or in this case in the left tubal ostia, all of these mimic the appearances of an interstitial ectopic pregnancy. You have to work out whether in fact it's lateral eutopic or whether it's partial interstitial ectopic pregnancy. And it's very important to go through a systematic approach, looking at the patient's symptoms of pain and bleeding, examination findings of tenderness, and scan findings of free blood within the pelvis, and laboratory findings of slowly rising beta HCG or HCG patterns. So it's a combination of all those four: the history, physical examination, scan findings, and laboratory testing will help you distinguish between the two. I would like to take you through some examples because some can be quite challenging. I don't think any of you would struggle with this. This is a lateral eutopic pregnancy, and with 3D with volume contrast imaging, you can see here the trophoblast ring, which is entirely enveloped by the surrounding decidua. This is a lateral eutopic pregnancy. It is not interstitial. This may be more challenging. On sagittal imaging, there's nothing really to appreciate. It looks like a straightforward intrauterine gestation. However, when you come around to looking at this on a 3D coronal image, you can appreciate that you may mistake this as being a partial interstitial ectopic pregnancy, but in fact this is a normal lateral eutopic pregnancy in a cavity that is not triangular. We do not use the term for this as being an angular ectopic. We do not use the term coronal ectopic. It is not interstitial. It is lateral eutopic. In this case here, it can be a little bit more challenging as you come across on this. Let me actually show you the 2D. So this is the uterine cavity here, which comes up and just about envelops the gestation sac. This is the trophoblast ring. This is the decidua. It can be hard to appreciate the decidua going all the way around the gestation sac And this is where 3D comes in, because you can follow the line of the decidua and the interface between the decidua and myometrium and realize that this is enveloped. It would be so easy to mistake this diagnosis as being an interstitial ectopic pregnancy, either partial or indeed complete, in the hands of the inexperienced. This is not angular, this is not interstitial, this is not cornual, cornual referring to presence of an ectopic pregnancy in a redundant horn, but rather this is a lateral eutopic pregnancy. Other cases may be challenging. In this case here, you see a gestation sac fundally within the uterine cavity, and as you follow the trophoblast ring all the way out to the right tuberostia, you can appreciate that it comes really a very subtle bulge of the uterine cavity, and here you can see this subtle bulge of the uterine cavity in another case. But all of these are lateral eutopic pregnancies. Now let's move on to some of the rarer forms of ectopic pregnancy, which is an intramural ectopic pregnancy and a pregnancy in a redundant horn. So in this case, you sweep across the uterus and you see a gestation sac located here within the muscle. From there, you move on to a 3D volume and see the uterine cavity, and you can appreciate that there is a gestation sac, a yolk sac, and an embryo located within the myometrium. And this shows here a 3D rendered image using HD Live, showing this is an intramural gestation sac here and an empty uterine cavity. This typically happens in patients who've had a previous uterine perforation, previous myometry, or previous classical cesarean section. And a partial intramural, as you sweep across this in the coronal section, you can appreciate the trophoblast ring communicating with the decidua, in a sense similar to the partial interstitial ectopic pregnancy. And this is referred to as a partial intramural ectopic pregnancy. As you come across, you see the trophoblast ring, but follow it, and you see that that communicates with the decidua. Then we talk about the ectopic pregnancy that occur in a rudimentary horn. It may be a horn that's fused or a horn that's separate. So if we look at this here, diagrammatically here we have a rudimentary horn containing an ectopic pregnancy, and surgically this is the fallopian tube coming out of the main uterine body, and this is the fallopian tube here connected to the ectopic pregnancy in a redundant horn. These are extremely challenging diagnoses. If we look diagrammatically in the top left-hand corner, this is non-communicating. It is separate. So we look here in this gestation sac here, we see an embryo, a yolk sac, and the limb buds. As we sweep across, the uterine body and pregnancy disappears, and we come across to the midline, and now the cervix comes into view, and here we have the uterine body. Again, to distinguish that the cervix is not actually connected to this gestation sac, to this uterine body, can be extremely challenging. And in a sense, the importance of looking not only on sagittal imaging of a pregnancy, but also screening in the cervix to fundus view, in which you may appreciate that the uterine body is entirely separate from the ectopic pregnancy in the redundant uterine horn. Difficult diagnosis, frequently missed on ultrasound, and complicated with rupture and hemorrhage and bleeding. We next move to cesarean scar ectopic pregnancy, and there are different classification systems for this. I'm going to stick with Escher and the partial and complete types of scar ectopic pregnancy, and then I will talk about low implantation or the low eutopics. For many of these ectopics, they occur in a pre-existing niche, and this is an example of a retroverted uterus with a striking niche here, 3D representation of the same niche demonstrated in the bottom left-hand corner. If we look at the Escher classification, whether it's on the scar, in the scar, or through the scar, and matching sonographic examples in the three images or three cine loops are demonstrated below. Of course, the ones that you worry most about are those that bulge out towards the urinary bladder. The earlier they are, the easier they are to treat. The larger gestation sac size is, the more bulge into the urinary bladder. The later in gestation, the harder they are to treat. There are different classification systems that then just been recently published, which Elan will maybe talk about, is another type of classification, type 1 and type 2, depending on whether there's less or greater than 50% protrusion into the uterine cavity. And this article is very well worthwhile a read, with many co-authors, including Davor Djokovic, with a large series of scar ectopic pregnancies. And this is beyond the scope of my talk today. I will, however, go through examples of it. This is a patient, when you go back to this image, you'll see she has Crohn's disease with multiple laparotomies as a colostomy and severe abdominal adhesions, an IVF pregnancy, sadly ending up as a scar ectopic pregnancy. So in our past history, having had a previous cesarean delivery. So as you scan through this, you see signs of the pregnancy, which is outside the uterine cavity. So this is the uterine cavity here, and this is where the pregnancy is entirely within the cesarean section scar. Patient present with vaginal bleeding and pain at 6 weeks and 3 days of gestation. Do not make the assumption what you're seeing here, the fluid is blood, particularly in a patient with a history of Crohn's disease and multiple surgeries. This is likely to be peritoneal inclusion cysts and fluid related to past surgery. Again, with 3D, we can distinguish the surrounding trophoblast, and this here is the cavity lying with the pregnancy entirely within the scar. But picking them up much earlier than this is an advantage because they are so much more treatable when they are so small. This is a very early ectopic pregnancy situated within the cesarean section scar with no bulge or extension into the uterine cavity. And another one here in the cesarean section scar, and follow the line of the cavity. You can see it sliding off here. This is entirely within the scar. These are all examples of complete cesarean scar pregnancies. If we look in this case here, we can see that this extends down inferiorly into the uterine cavity on 2D imaging and on 3D imaging. So this is a partial cesarean scar pregnancy. Again, Ilan will make the point not to call cesarean scar ectopic, but rather cesarean scar pregnancy. Then you have the low implantation or the low eutopic pregnancies. So this is a 3D evaluation of the uterine cavity where you see the gestation positioned low within the cavity, and here similarly low within the uterine cavity. Important in these to recognize that they have a higher chance of miscarriage, and they also have a higher chance of a morbidly adherent placenta. And this is important to make note of in your pregnancy report. Cervical ectopic pregnancies are rare, and many of these, when you look at these, may strike as being cervical ectopic pregnancies, but in fact they are miscarriages in progress. In this case, you can see it conforms with the shape, or gets compressed, I should say, as you sweep through it. And then you can see in a coronal image that spherical appearance of a pregnancy within the cervix. But really you need to push, and as you manually palpate, you see that this slides within the cervical canal. So there may be an embryo present and a heart motion present, but this is really a pregnancy miscarriage in progress. This is a much more sinister appearance of a mid-sagittal section through the cervix showing a gestation sac within the cervical canal. This the uterine body, internal os, and the cervix here with the pregnancy entirely within the cervical canal. In this case here, a very old case in the patient who has an empty uterine cavity. And if you look at here, the pregnancy is entirely within the cervical canal, but much later in gestation with a very strong vascular appearance. And remember, if you ever see an IUD in situ and a coexistent pregnancy or positive beta HCG, it's likely to be a coexistent ectopic pregnancy. And in this case here, another partial cervical ectopic pregnancy. I'm going to finish up. I'm slightly over time with the abdominal pregnancies. So this here is an example of an empty uterine cavity. Up here we can see a patient who's at 8 weeks and 2 days of gestation, a dating scan. The beta HCG is at 28,000. As we come up here, we see that there's a typical trophoblast here of a dichorionic twin gestation. And then using 3D with VCI static, we can appreciate that there are two gestation sacs, one smaller than the other in a patient with a primary abdominal ectopic pregnancy. Then there's the abdominal ectopic pregnancy, which are secondary, and these are ectopic pregnancies that are extruded through the fallopian tube. So here we have an extruded ectopic pregnancy here with the gestation sac, yolk sac, and embryo, and another one here sitting in the pouch of Douglas. These were not primarily fertilization taking place in the abdominal cavity, but rather in the tube and being secondarily extruded. And lastly, and not least, is the ovarian ectopic pregnancy. This is a sweep comparing both left and right pelvic sidewall. This is the ovary on view on this side on the right, and then sweep across. You can compare to the opposite side. You can see a gross enlargement of the left ovary in a patient with a HCG of 80,000. And you can compare the size of the ovary indeed to the size of the uterus and realize the gross enlargement of the ovary in this case. When you look at the texture of the ovary, it's got a very abnormal appearance, but when you apply 3D VCI static, you can appreciate that this is all trophoblast and this is the edematous ovary. But it's color that's so striking when you see it lights up like a Christmas tree. And these are the surgical findings demonstrating a normal left ovary, normal fallopian tube, and then over to the ovary on the opposite side. You can see why these ovaries bleed so much when they rupture later. So I've covered in summary the different types of ectopic pregnancy, both by graphic demonstration and following according to the ESHRA guidelines. And I ask you the question, what difference does this talk make to you when you go to work tomorrow morning? Well, I think the first thing is it's important to understand the ESHRA classification and ensure that we all use the same terminology. Secondly, that 3D is a very powerful tool, and not so much in terms of rendering, but rather in terms of borders between tissue and aiming to get maximum contrast and understanding what's trophoblast and what's edema, and adopting the 3D technologies to get to that end. I know most ectopic pregnancies are in pulmonary, but always have in the back of your mind the rare forms of ectopic pregnancy, particularly when you've got high HCG and after repeated scans, no signs of an intrauterine pregnancy. You must think of the rarer causes. Be careful of the low implantation pregnancies because of the high chances of placenta accreta later. And also for those miscarriages in progress, don't make an early and enthusiastic overcall of cervical ectopic pregnancy. I'll stop there. I've gone a little bit over time. Again, thanks very much for your attention and for the opportunity to present here this evening. Bye for now.
Thank you so much, Simon. That was a very, very interesting lecture for us all. And now I would like to invite all the faculty for a discussion. We have nearly 25 minutes for discussion now, and I don't see Simon with us, but I see Maya